Mina, we can start now.
Okay. Welcome everyone. Today is our final session for Geriatric month. Today we have a very interesting topic. Let's learn how we can approach confused patients better. So today, our speaker, Dr. Nur Azlina, will be talking about differentiating dementia from delirium. Before that, let me introduce you our chairperson, Dr. Riza Mazwin from Hospital Kuala Lumpur. And so today, let's listen to them. So Dr. Riza, it's all yours.
Thank you, Mina. Assalamualaikum and a very good afternoon, everyone. Thank you for spending your afternoon with us today. It is my great pleasure to introduce to you Dr. Azlina, my colleague that I've known for more than 5 years. Dr. Azlina graduated with Masters in Internal Medicine in 2012 from UKM. She completed her fellowship in geriatric medicine training at the MOH in 2018. And she is currently the consultant physician and geriatrician at Hospital Raja Permaisuri Bainon, Ipoh. And she has been a member of many national and hospital committee concerning internal and geriatric medicine. And she is actively involved in research and publication at national level. So without further ado, Dr. Azlina.
Thanks, Dr. Riza. Assalamualaikum and good afternoon, everyone. Thanks, College Physician, for inviting to talk on the geriatric webinar series. I'm a bit stressed out because I'm actually the last speaker for the series, and I think the previous speakers has actually done very well in their webinars. All right, so the topic today is confused patient, differentiating dementia from delirium, and I hope you, after we finish this session, you won't become furthermore confused, right? Okay. Oops, it's not moving. Right. Well, I'm not a horror movie fan, but one of our colleagues actually posted this in one of the WhatsApp group, and I thought, oh, it's actually quite relatable to what I'm talking about today. So dementia and delirium have been conceptualized as a distinct and mutually exclusive conditions. So even the DSM-5 states that dementia should not be diagnosed in the face of delirium, and that delirium should not be diagnosed when symptoms can be better accounted for or by a pre-existing, established or evolving dementia. So distinguishing between these two diagnoses in clinical settings can be difficult, even for experienced clinicians. And delirium symptoms can persist for months or even years, and the recognized condition of persistent delirium blur the boundaries between these previously demarcated syndromes of cognitive impairment. So differentiation between delirium and dementia is crucial importance since the assessment and clinical management are distinct. So the outlines of the talk today is we're going to talk about delirium and dementia separately. And after that, we go through the relationship between delirium and dementia. Then how do we differentiate or distinguish delirium and dementia? There will be, then we talk about how to assess, how to assess delirium, and a very brief slides on management of delirium. And we also have a one case study in between as well. So delirium is defined as an acute disturbance in attention and cognition that develop over a short period of time. So it's acute, right? So despite its high prevalence, it often remains unrecognized. With a recent study shows that a rate of undetected delirium is about to be as high as 60%. And delirium can be life-threatening condition, yet it is often preventable. Hospitalized patient who develop delirium has high risk for long-term cognitive and functional decline, which will increase the post-hospitalization treatment cost, and this would include institutionalization, rehabilitation, and home healthcare services. Right. So this slide is basically, we are talking about prevalence and incidence of new onsets, prevalence and incidence rates of delirium in various patients' populations. So highest incidence rates were observed in intensive care and palliative care settings. These rates are likely to be underestimated though, because many studies of delirium exclude patients with cognitive impairment or dementia at baseline who are particularly vulnerable. Delirium has been associated with poor outcomes, including mortality, right? Patients with delirium in general medical or geriatric ward has at 1.5 to 1.6 fold increased risk of death in the following years. And delirium in the emergency department also, delirium in the emergency department down below here also associated with increased risk of death. And delirium in the post-acute care also has nearly five-fold increased risk of mortality. And then the other thing is delirium is also associated with cognitive and functional decline. So the long-term cognitive and functional impairment, delirium in the ICU is associated with cognitive impairment up to 1 year post-discharge. In a cardiac surgery patient, a longer duration of delirium, more than 3 days, was associated with greater decline in cognitive function after surgery, followed by a slower cognitive recovery over the ensuing 12 months. Physical function is also more significantly impaired after discharge among surgical and non-surgical patients who develop delirium. So a recent study showed that delirium was associated with persistent and clinically meaningful impairment of functional recovery up to 18 months later. So delirium, high mortality, and also can cause long-term cognitive and functional impairment. Right. So this is basically the diagnosis. How do you diagnose delirium? Either you use DSM-5 or if you use ICD-10. Both DSM and ICD has put on attention, awareness, timing of fluctuation, and memory in their diagnosis. ICD-10 actually includes psychomotor deficit and sleep disturbance. So according to DSM-5, delirium is disturbance in ability to direct, focus, sustain, or shift attention. There's also disturbance in awareness, develops quickly, hours to days, and represents a change from baseline and fluctuates over a day. There's also additional disturbance in cognition, such as memory deficit, disorientation, language, visual spatial ability, or perception. In ICD-10 include psychomotor deficit and sleep disturbance. So at least one of the following psychomotor disturbances. So either it's rapid, unpredictable shift from hypoactivity to hyperactivity, increased reaction time, increased or decreased flow of speech, or enhanced startle reaction. There's also disturbance of sleep-wake cycle manifest by at least one of the following, either insomnia, or nocturnal worsening of symptoms, or disturbing dreams and nightmares that may continue as hallucination or illusion after awakening. All right. So I'm sure that you guys have heard of CAM, or Confusion Assessment Method for Delirium. So sorry. So, So confusion assessment method CAM for delirium, it has 4 criteria. So just now we went through the diagnosis of delirium of acute onset and fluctuating. And so you has to have criteria 1 and 2, acute onset and fluctuating, or criteria 2, which is inattention. All right. And criteria 3, 1 plus 2, or and 3 or 4. Criteria 3 is disorganized thinking. Criteria 4 is altered level of consciousness. This CAM for delirium has high sensitivity and has high sensitivity and specificity as well. Delirium starts, so delirium has also subtypes: hypoactive, hyperactive, and mixed. So delirium start with the vulnerability to delirium such as dementia, older age, and polypharmacy. And it has a precipitating events, be it a hospitalization or hip fracture, and then this will induce delirium. So delirium subtypes, as you know, there's 3: hypoactive, hyperactive, and mixed. And with hyperactive, usually this is one is undetectable because everyone is happy, patient is quiet. So they usually is lethargic, they have reduced psychomotor function, but it has poorer prognosis. In hyperactive, they are rarely unnoticed because they are agitated, they have increased vigilance or sometimes hallucination. And mixed is where they are actually fluctuate between hyperactive and hyperactive. And this one is also challenging because you have to observe when they actually fluctuates. Right. So this is a famous figure or model, a multifactorial model for delirium from Inoue. This development of delirium involves a complex interrelationship between baseline patient vulnerability. Here, my little pointer is actually a bit slow. So this is a predisposing factor of vulnerability with, and also the precipitating factors or noxious insults occurring during hospitalization on the right axis, right? So it's commonly multifactorial in older adults, older persons, although a single factor can precipitate delirium, but the development of delirium typically involves complex multiple predisposing factor that make a patient more vulnerable to insults and the degree of exposure to the insults or precipitating factors. So such, for example, is if a patient, a single low dose of sleeping medication or sedative or benzodiazepines given to a patient who is cognitively impaired may lead to delirium. However, a patient without severe illness, the healthy fit elder without chronic condition, given all the noxious insult, whether it's a surgery, ICU stays, and multiple psychoactive medication, before they might actually could withstand all these noxious insult before developing delirium. So addressing only a single noxious insult is likely insufficient in preventing or improving delirium. Rather the multi-component approaches are recommended for both prevention and treatment. So the leading risk factors for delirium actually consistently identified in both medical and the surgical population are dementia, cognitive impairment, functional impairment, visual impairment, and history of alcohol abuse and older age more than 75. Comorbidities or severity or illness or presence of any specific comorbidities such as stroke and depression associated and in an increased risk of delirium in all patients population. ICU patients included younger patients, and therefore baseline factors such as dementia or functional impairment maybe were not significant predictor of delirium. So precipitating factors for delirium, just now we talked about predisposing factors. Now, what are the precipitating factors? This is the commonly that we have to look up in the patients in the ward. So whether it's polypharmacy, use of psychoactive or sedative hypnotic drugs, use of physical restraints, use of bladder catheter, any physiological and metabolic abnormalities such as high urea, high creatinine, low sodium, high sodium, sugar, glucose, hypoxemia, or metabolic acidosis. We need to rule out infection, any iatrogenic event, major surgery, trauma, or urgent admission to hospital or coma. So in medical patients, the bold one, the polypharmacy, psychoactive or sedative hypnotic drugs and physical restraints were the leading factors, conferring up to 4 to 5-fold increased risk in delirium. So just now we talk about delirium. Now we move on to dementia. So dementia is a insidious neurodegenerative condition characterized by chronic and progressive cognitive decline from a previous level of performance in one or more cognitive domain. This is according to DSM-5 criteria, which the domains are learning and memory, language, executive function, complex attention, perceptual, motor, social cognition. I actually prefer the DSM-4 criteria. It's more because it's sort of like more practical. So you have to have a memory impairment and at least one of the following: aphasia, apraxia, agnosia, and disturbance in executive functioning. But both DSM-4 and DSM-5 stated that the cognitive deficit do not occur exclusively during the course of delirium. So what are the relationship between delirium and dementia? So baseline cognitive impairment or dementia is an important independent risk factor for delirium, about 2 to 5 times. And delirium also is an independent risk factor for long-term cognitive decline and dementia. So there's like vice versa. Right. So this is just a model of a hypothetical model for the pathophysiological relation between delirium and dementia. Right. So delirium is a known risk factor for a new onset of dementia and could arise as a direct result of stroke, hypoxia, metabolic abnormalities, or drugs. And this delirium causes alteration in neurotransmitter concentration, neuronal dysfunction, and neuronal death. And this will lead directly to dementia. Anesthetics also has growing evidence that some anesthetic associated with post-operative delirium might accelerate beta amyloid pathology and cause apoptosis, which in turn might suggest a role for this anesthetic in new onset dementia. Indirectly also, delirium is also likely to be a marker of dementia in patients with preclinical or pre-existing dementia and might accelerate existing condition to dementia. This might occur indirectly, for example, via the inflammation triggered by systemic infection or exaggerated response to a stressor. Right. This figure basically just to understand the relationship between delirium and dementia. The 3 trajectory lines are basically to describe different older adults who undergo stressful events such as major surgery and or any illness requiring hospitalization. So those who did not get who didn't develop delirium, which is this black line, right? Older adults are more vulnerable to cognitively to stressors. So cognition, this is the cognition, the axis of cognition. So the cognition actually declines a little bit, but recovers back to the baseline easily. And if you follow up these older patients for 36 months on average, their cognition may start to decline. As we know, because we know the prevalence of dementia rises with age. The 2 red lines down below is an older trajectories, older adults with trajectory with delirium. Notice that those who get delirium actually typically have a lower cognition to begin with, and then delirium causes a marked decline in cognition over hours, and 2 days followed by a slow recovery. Older adults undergoing elective surgery who gets delirium takes about 2 months to recover, while the medical patients usually take about 6 to 12 months to recover. The difference is due to the baseline risk, as we know the medical patient usually typically being more frail compared to the surgical patient. And then note that despite the recovery cognition may not return to the baseline, to their prior baseline. In patients with prolonged or more severe delirium, they may even further from their cognition baseline after recovery. And the challenge of delirium across different types of dementia is possibly overall the overlap with behavioral and psychological symptoms of dementia, right? So clinical phenotypes of dementia should show some overlap with delirium. For example, fluctuating cognition is seen in AD, Alzheimer's dementia and vascular dementia. However, the prevalence and severity of fluctuation is greatest in dementia with Lewy body, DLB, right? It's also important to differentiate delirium from dementia or recognize when delirium is superimposed on dementia. Delirium superimposed on dementia results in worsened cognitive and functional decline and increased hospital length of stay as well. So for dementia, Alzheimer's disease is the most common type of dementia, and it can be easily separated from delirium because of its insidious slow onset and preservation of attention in the early stage. But dementia Lewy body is less common type of dementia, but it can mimic delirium because of its fluctuating cause and inattention. We'll discuss it a bit more after this. So delirium and can be distinguished from dementia. This is basically just a comparison of delirium and dementia. So it can be easily distinguished by the onset. So delirium is abrupt, although initial loss of mental clarity can be subtle, but in dementia it's insidious and progressive. And duration is in delirium hours to days, although it can be prolonged in some cases. In dementia, months to years. So in delirium, attention has reduced ability to focus, sustain, or shift attention is a hallmark features that occur early in presentation. So attention is the hallmark of delirium. And in dementia, attention is usually normal except in severe dementia. So the other difference is consciousness or the awareness of the environment. In delirium, they're fluctuating. Thus, as assessment at multiple time points is necessary. So they have reduced level of consciousness and impaired orientation. Dementia is generally intact until it's quite advanced. In delirium, the speech is incoherent and disorganized or distractible in conversation. In dementia, usually is still in order, but development of anomia or aphasia is possible. And delirium, of course, the cause is the underlying medical condition or drugs or substance intoxication. In dementia, there is underlying neurological process. The other features of delirium, because just now we say about psychomotor, hyperactive, hypoactive, and mixed form as determined by the type of psychomotor disturbances or possible disruption in sleep disturbance and architectural perceptual disturbances. In dementia, symptoms vary depending on the underlying pathology. So fluctuation in cognition are features of DLB. So dementia of Lewy body or DLB has a core clinical features. The first three typically occur early and may persist throughout the course. So one is fluctuating cognition with pronounced variation in attention and alertness. Recurrent visual hallucinations that are typically well-formed and detailed. REM or sleep behavior disorder, which may precede cognitive decline. One or more spontaneous cardinal features of Parkinsonism are either bradykinesia, tremor, or rigidity. And prominent or persistent memory impairment may not necessarily occur in the early stage, but is usually evident with progression. So delirium and DLB, so there is some overlap and there's some differences. So delirium usually, again, the onset is acute and DLB is gradual and progressive. In cognitive impairment, there's overlap features of delirium, DLB. They can have fluctuation in attention, executive functioning, memory, or visual spatial deficits. In delirium, the perceptual disturbances, it could be visual and auditory hallucination. And DLB is more of like recurrent structured visual hallucination. In delirium, they have disturbance in sleep-wake cycle, and DLB, they have REM, sleep behavior disorder. REM is a sleep disorder which you physically act out, vivid, often unpleasant dreams with vocal sounds and sudden, often violent arm and leg movements during REM sleep. Sometimes it's called dream enacting behavior. In delirium, the motor signs are hyperactive or hypoactive. In DLB, the features are Parkinsonism. And the neuroleptic sensitivity is also a feature of DLB, where they actually have severe neuroleptic sensitivity, and in delirium is not present. Differentiating delirium and DLB is vital to guide initial management and safe prescribing. Incorrectly diagnosing an acute change as a deterioration in patient with existing DLB rather than delirium can result in under-investigations of common cause of delirium, such as infection, medication, pain, and inadequate management of this potentially life-threatening medical emergency. Conversely, the lack of recognition of undiagnosed DLB in someone with delirium may result in patient being treated with antipsychotic medication. And as I said just now, it has severe neuroleptic sensitivity. Such agents can significantly worsen features of their DLB, such as Parkinsonism and cognitive impairment or arousals. And this also increases the risk of mortality. The other features of delirium and DLB just now is the similar features of fluctuations. I'm just going to mention a bit about sundowning in Alzheimer's dementia, because some might consider it as a fluctuation, but it's actually not. Sundowning is not considered true fluctuation, but rather sundowning is a consistent pattern of behavioral change that happen in the afternoon or evening hours. This usually starts in moderate to severe disease, and sundowning should be presumed to be delirium when it is a new pattern, and patients with established sundowning and no obvious medical illness may be suffering the effect of impaired circadian regulation or nocturnal factors in the institutional environment, such as shift change, noise, or reduced stuffing. Deliriums always deviate from patients' usual behavior pattern, either by timing or severity, and associated with precipitants, as we talked about just now, medication, infection, or hospitalization itself. So in DLB, fluctuation may last hours or days and does not follow a pattern. Like sundowning has a pattern every afternoon or every evening. Fluctuations are typically delirium-like, occurring as spontaneous alterations in cognition, attention, and arousal, not due to precipitating factors. And characteristics of fluctuations include wax and waning episodes of behavior inconsistency, incoherent speech, variable attention, or altered consciousness that involves staring or zoning out. Direct questioning of an informant about fluctuation may not reliably discriminate DLB from AD, but questions about daytime drowsiness, lethargy, staring into space, or episodes of disorganized speech do. So how do we assess, how do we decide whether this is delirium or whether this is dementia? Right, so the most reliable way is basically whether someone with dementia or has delirium is by an informant, a family, a caregiver who knows the patients well. So, so basically you just ask, do you think this patient has been more confused lately? This question is actually validated as the single question in delirium, and sensitivity proved to be 91%, which is a remarkable as a screening tool. So check with the informant and look for fluctuation, assess for inattention. So check with the informants, the most important thing is actually history. So check the baseline cognitive function. The important key is baseline cognitive function and recent change in mental status, either it's from the family or from the staff. Recent changes in disorder, new diagnosis, complete review of the systems, review all the current drugs, including over-the-counter and herbal preparations, pay special attention to new drugs and drug interactions, review alcohol history and sedative use, assess for pain and discomfort such as urinary retention, constipation. Geriatricians is very anal about constipation and also dehydration. Fluctuation, as we said just now, the patient experiences periods of lucidity in between episodes of increased confusion, and the patient likely has delirium. And we have discussed about TLB as well just now. Inattention. So inattention is a hallmark of delirium. So did the patient have difficulty focusing attention, for example, being easily distractible, or having difficulty keeping track of what was being said? So reduced ability to maintain attention to external stimuli and to shift attention to new stimuli. It's unaware or out of touch with environment. Sometimes they are just dazed, fixated or darting intention or no eye contact. Sometimes they're fidgeting with the clothes or playing with the mattress or things like that. Difficult to establish back and forth conversations. Errors on attention test or misdirection repeated. So inattentions, this is just few tests that you can do to assess inattention, and we go back to CAM score later after this. So attention testing can be done. So inattention, sometimes you just basically by observation, but sometimes it's a bit difficult to observe if you find it difficult to observe inattention. So objective measures is another way of assessing inattention. So can be done a variety of bedside tests. Many use months of the year backwards as the way to identify inattention. So you tell the patient to recite the months of the year forward first. And if they are unable to recite the months of years going forward, means maybe likely they are inattentive. And this is high specificity for delirium. If they are able to recite the month, then ask them to tell you the months backwards from December. Doing it this way has the additional benefit of ensuring that they actually know the months of the years. But I suppose sometimes it's a bit difficult in our population. Or because sometimes your uncle or aunties or your pakcik or makcik will say bulan 1, bulan 2. So they don't usually use January, February sometimes. Okay, so this so you can use alternative tests of attention such as digit span, which we'll talk about later. It's like something similar to the one that is on MOCA. You can recite 3 to 5 digits and tell the patients to repeat the digits in reverse order. This is another ways of also days of the week backwards, but it's actually quite low sensitivity, although it's specific. And or counting 1 to 10 is actually is low sensitivity because it's quite easy. Series 7, like MMSE, has high sensitivity, but it's not good for specificity in assessing inattention because the test is harder, and many people with dementia without delirium or those with low education will not be able to complete the task. And the counting 1 to 10 is really specific, but not good for sensitivity because it's too easy. So just now we talked about CAM, the features of delirium. You should have acute onset fluctuating, inattention, and disorganized thinking or altered behavior, altered consciousness. Sorry. So CAM has been adapted in many settings, in ICU, in emergency, nursing homes, palliative care. And there are about more than 25 delirium screening tools that have been developed. And later on, they come up with this 3D scan, 3D, not scam, CAM, which provide assessment in 20 items checklist that streamlines the evaluation of the CAM features, the 4 CAM features with high sensitivity and specificity. So this is like this. Right. So this is the flow of the 3D scan. So the features one, just now we talked about acute change of fluctuating cause, also any one of the following present. So answering assessment questions, self-report or confusion, or you notice disorientation or hallucination. Observe fluctuation also in consciousness or attention. If acute change of fluctuating, it's yes, then you have to assess for inattention. So inattention, any one of the following assessment, either digit span 3 backwards, you just give few numbers and then you ask them to say it backwards, or days of week backwards, month of year backwards, trouble, or at the same time, you have to observe whether they have trouble keeping track of interview or inappropriately distracted. So if yes, if no, then this is not delirium. So if yes, then you have to do features 3 and feature 4, whether disorganized thinking. So you ask about orientation to year, day of week, type of place, observed also at the time flow of ideas, whether it's unclear or illogical, conversation ramblings, off target or abnormally sparse. So if it's present, yes. So this is delirium present. So I mean, if this is already present, you don't need to go further to the feature 4. So, but if the disorganized thinking is not there, then you have to assess the altered level of consciousness, where the patient is sleepy, stuporous, comatose, or hypervigilant. So this is the 3D CAM assessment. I think you can actually Google it up. So basically there's 10 questions, objective questions, but it's also include observer ratings, about 10 observer ratings as well. Right. So I think the easiest one to do is a brief test is a 480 test. It has sensitivity of 90% and specificity of 80%, 84%. So 480, basically you just you assess alertness, you assess AMT4, which is age, date of birth, place, which is name of the hospital or the building, and the current year's attention, and which is the same also as 3D CAM assessment just now. So tell the months of the year backwards or order starting from December, or acute change of fluctuating cause. This one, I think I like it because it's easy and it's actually on the mdcalc.com, which you can actually just fill in the numbers, and then it came up with the points and whether it's delirium or not. So assessment in delirium, just now, so we assess the history. History is the most important thing, and then assess the fluctuation and inattention. But you also have to do the usual assessment, physical and neurological examinations, check for vital signs, whether hypoxia or what is the glucose, what's the temperature. Search for signs of occult infection, dehydration, abdominal pain, deep vein thrombosis or other acute illness. Assess for sensory impairments as well, and search for focal neurological changes and meningeal signs. And then we proceed to targeted laboratory assessment. You should consider blood count, urinalysis, your RP, renal profile, calcium, glucose, thyroid function, cultures of your urine, blood, and sputum, drug concentration, if it's if on any drugs that you can measure, measurements of concentration of ammonia, if it's hepatitis, encephalopathy, B12, and cortisol, arterial blood cases in cases that you suspect the hypoxia or hypercapnia, ECG, patient who presented sometimes elderly, they present atypically and they might actually have MI, chest radiography to rule out pneumonia, lumbar puncture, for if patient that you're suspecting meningitis or encephalitis. Targeted neuroimaging, assess for neurological changes. A stroke can present as delirium, or those who you suspect encephalitis. EEG is only in selected patients. If you think the patient has, you need to assess patient for absence seizure or caught seizures. All right, so we're nearly done. So this is a case study. So Mr. J is an 80-year-old lady who was brought by her daughter, to the hospital for visual hallucination and confusion. So is this delirium, or is there underlying dementia? Or if it's delirium, what's the precipitant? So the most important is history from a reliable informant. So what you ask the daughter is, when did the confusion start? So she has been confused for the last 2 years, getting worse. So she frequently forgets conversations and where she put things. So she already has cognitive impairment there, right? A chronic progressive cognitive impairment. What was the patient's cognitive baseline 1 week or 1 month ago? She was much better a few days ago, and this hallucination only started about 2 days ago. And she also started feeling short of breath at the same time. So there is acute worsening of this cognition, and also there's maybe a precipitant or precipitating factor there also, right? So does the patient have diagnosed dementia? I mean, basically you ask the daughter whether has she been diagnosed with dementia. No, at first we thought it was just because she's getting old. Okay, right. So is this delirium or dementia? So you do your CAM score criteria 1 and 2, acute onset and attention. So there is some acute change from her baseline, right? And you do the inattention test. She gets stuck at November. And also when you ask for orientation, she basically disorientated to the time and place. So what she has is acute change on a background of chronic progressive cognitive impairment. So this is delirium superimposed on dementia, which is quite commonly seen in patients that referred to this. So in this case, just now, tests for inattention were positive, and the patient had disorganized thinking, disorientation, and hallucination. So the CAM criteria is fulfilled. Just a very brief slide on management of suspected delirium. So in management, whether you need to do drug adjustment, reduce or remove psychoactive drugs such as anticholinergic, sedatives, or hypnotics, opiates, reduce the dosage if needed, or substitute with the less toxic alternative. Or you use non-pharmacological approaches for sleep anxiety, including music, massage, relaxation techniques. Address if there's any acute medical issue, maintain the hydration, treat hypoxia, reorientation strategies, so encourage the family involvement, use companions as needed, address sensory impairment if they are short-sighted, whether they need eyeglasses, or whether their hearing aids are also needed. Avoid use of physical restraints, ambulate patient at least 2 times per day, which may be difficult, but if the family is around, it would be possible. And encourage self-care and regular communication. To normalize sleep-wake cycle, we discourage napping and encourage exposure to bright light during the day. Try to provide uninterrupted period for sleep at night, and provide non-pharmacological sleep protocol and quiet room at night with low-level lighting. Pharmacological management is reserved for patients with severe agitations that interrupts essential treatment, such as intubation or severe psychotic symptoms. But if you have to start, you start with low dose and titrate it until effect achieved. Either it's haloperidol or your atypical antipsychotics. Right. In summary, delirium and dementia is most common cause of cognitive impairment, but there are actually 2 different entities. Delirium is acute. The hallmark is inattention, and dementia is chronic progressive. But they are related. Dementia is the leading risk for delirium, and delirium also could increase cognitive impairment and functional decline, and they can coexist, delirium with superimposed dementia. How do you differentiate? Important thing is assessment. History is very important in differentiating this, and assess for inattention and fluctuation. All right, I think that's all. Thank you.
Thank you, Dr. Astina, for the very comprehensive talk. And there are quite good new information for me as well. So far we have two questions from the attendees. The first question is from Dr. Grace Lau. Her question is, MMSC currently has the Holstein charges when using this officially. What do you think of the slums, the St. Louis University mental state examination? Do you use it much to assess for cognitive impairment?
Slums, is it? The question is for slums.
Yes.
Okay. I have to say I started to use it, but not much. But it's quite I've tried it once on my occupational therapist. I thought that the story part is actually quite difficult, but it's actually they find it quite interesting. But to say I use it only on few patients, and so far I think it's quite easy. Still, you have to choose the patients that you want to use, same as like MOCA or MMSC, which one, what kind of education level that you want to patients that you want to use the slum. It's quite, not to say easy, but it's quite reliable. But I have to say that I don't have much experience using it. I think I only use it for one or two patients and few patients for some study. I think you use it quite a lot, Lisa.
Yeah, I think I, like you, I actually prefer slums to MOCA. How it is designed, I think it's a bit more user-friendly. I mean, like MOCA is probably not that relatable to our culture. Of course, there are the Malay version, more validated, but there are certain areas of slums that I feel it doesn't sound too much like you're challenging a person's cognition. It can sound more friendly, and the person may feel a little bit less anxious doing it. But there's also in a Malay version now. I think it was already validated. It was translated by Prof. Akisan from UiTM. So personally, I would actually think that I would encourage, or if you want to give a different feel. But of course, like you said correctly, we don't use slums. Whom do you want to choose? Because slums is validated for MCI rather than to diagnose dementia, as opposed to MMSC. So you probably have to be very careful in interpreting the questions, the scores when you do slums to diagnose dementia. There's a second question. I think this is from our trainee, Dr. Dear Doctor, thanks for the detailed talk. As delirium can last as long as 6 months, how do you determine when and how the patient can be safely managed as outpatient?
Well, delirium could last more than that. Cognitively, delirium can last up to a year and more. How do you determine when and how the patient can be safely managed as outpatient? I think once you settle the acute issue or the precipitating factors that cause the delirium, and safely patient can be discharged from the inpatient or from hospital, and you already educate the family on what is delirium and how do you deal with delirium, then I think they can actually be safely managed as outpatient. But of course, you need to follow them up as well. So because, as we said, sometimes one, we want to assess whether worsening delirium, or we want to assess the cognition again after that. But as long as the patient acute issue is sorted, I think it's quite safe to discharge, as long as you provided the family with a good education on managing or handling delirium at home.
Okay. Next question. 65 elderly woman COVID Cat 4 with organizing pneumonia.
For you, Ariza, you're managing COVID. I don't manage COVID.
On IV dexamethasone 3 days, then oral dexa for another 5 days, patient delirium. Is that the only question to it? I think it stops there. Probably asking about steroids-induced
psychosis,
psychosis, or is it COVID induced delirium?
neurocognitive
Neurocognitive component
part of COVID. I don't know. But because I don't manage COVID, so I don't know actually. But I think when the COVID first started, when the hydrochloroquine was used, we were worried of the prolonged QT interval, especially when we used the antipsychotic. But now, I suppose it's okay. But somehow when they consulted me on delirium patient with COVID, somehow they managed the patient non-pharmacologically. So I think the non-pharmacological management is still very important, but maybe it's difficult to do in the COVID ward. But I think you should consider that rather than the antipsychotic use, because it all comes with the side effects. Yeah. What do you do, Riza, in your settings?
In us,
Yeah.
We have 130 patients, and some of them try to run out from the ward. A lot of them actually don't want to eat because they have anosmia, they have anemia. We have to convert to using a lot of our own nutritional supplement. And we have one patient who just tried to run out of the ward because his wife was in my apes. And he's been sent to HRCs where extract the wife from my apes. And that actually sort out the problem of needing to, to sedate or anything. Anything as long as,
So find the precipitating factors. I mean, again, go back to the why is the patient delirious? Yeah.
But it can be quite tricky. With DEXA, it can cause the blood sugar to become deranged. It can also, the hypoxia, some of the patients just do not want to use the oxygen. And they are like saturating about 85% and they don't want to use the oxygen, and that make them delirious. So you have to resort to quite a bit of extra effort. Yeah, but sometimes in very life-threatening, they require higher level of oxygen. We do at times need to use antipsychotics, but we use at the lowest dose possible. Yeah. Okay, Dr. Rahana, sleep is a big problem to manage in elderly patients, not only in dementia. What are your thoughts on use of zolpidem long term?
Well, I suppose we all know benzodiazepines has a long-term cognitive side effects, especially on elderly. So use on long term, no. But I've used zolpidem infrequently in patients for short term. So benzodiazepines basically can cause a long-term side effects of neurocognitive impairment. So but there are of course patients who has chronic insomnia, which you just can't. You just have to give, I suppose, because they just keep asking you for that, or they also come from different doctors with all this chronic benzodiazepine usage, which you actually either very difficult to titrate down or to stop.
Yeah, so zolpidem is not purely benzodiazepine. It works on the subunit of the benzodiazepine though. Yeah, I agree. We will always try the sleep hygiene thing.
Yeah.
Yeah, it takes a lot of effort, but it usually works. But I totally agree with you. Benzodiazepine in long term actually cause a lot of problem, and the withdrawals or the dependency on the benzodiazepine sometimes is just very difficult to wean off from the patient. So do you use a lot of do you use something like Xanax or alprazolam?
I mean, yeah, sometimes short acting, but very infrequently. I mean, not as a long-term usage.
Yeah, we try not to use, but sometimes I guess sometimes you have to consider the quality of life of the caregivers as well.
Yeah, patient and caregivers.
Okay. So far, I think that were the only questions. Can I ask you a question, Dr. Zdina?
Can.
Let me just check. Is there any more questions? No. Okay. How do you differentiate delirium on the background of dementia, especially, those like your Lewy body dementia, where patients are typically very psychotic, and then this delirious patient, they can actually develop quite bad delirium with some psychosis features as well. Do you have any tips on how to differentiate that?
Well, I suppose from the slides just now, sometimes the fluctuation is a bit difficult to differentiate, especially in DLP. But I think I read somewhere, if you're not sure, you just treat them as delirium. And then again, I think it's always important to reassess the patient. That's why sometimes those delirious patients that we actually follow them up just to see whether they actually has cognitive issue later or not. So sometimes, DLB and especially DLB and delirium, sometimes they are difficult. But again, the history, if any, I suppose the trick is to get the proper history when is the onset. The proper history. And then sometimes you have to dig around, busybody a bit, just, that's what the geriatrician does. So I mean, you have to find the timeline of the story. So that's very important. But if you're not sure, just treat as delirium first. But I suppose as what I presented just now, sometimes you're worried when you're using the antipsychotic. This is DLP, undiagnosed DLP, you might worsen the condition. Then I think you learn your lesson from there.
The good thing is that DLP is not that common.
They are not that common. I think they are not that common. Or whether we are underdiagnosed them, but I think they are not that common as well.
Okay. Is there any more questions from the attendees? Does there to be any more questions, Dr. Mina? So over to you.
Okay, thank you very much. Thank you so much for all our speakers and our chairpersons for this entire month. This concludes Geriatric. So hope to see all of you